Kristoffer driving older adults. He works over at the Memory Brain Wellness Clinic here at Harborview. And I'm not going to spend too much time introducing him because he has a lot of wonderful things to say, and I want you to hear them. I imagine that driving an older adult comes up for a lot of you in the primary care setting. It's a challenging situation, so we're interested to hear what you have to say.
Great. Right. And then, does this click me through? Yeah. All right. Yeah, so just as a point of clarification, so I'm a neuropsychologist, and I am not a researcher, I'm a clinician. And a big part of what we do at Memory and Brain are evaluations of older adults that have different degrees of cognitive impairment, everything from subjective cognitive complaints all the way up through advanced dementia. And as you might imagine, driving is something that comes up frequently. I'm going to try to condense this down into about 10 to 15 minutes, and please do not let that belie the simplicity or the complexity of this issue. This is, for any of you out in practice, you know how thorny this is and how difficult this is. But there are a few things that are worth addressing. Number one is that this is a highly frequent problem. We have about 1.5 million elders with dementia who are currently driving. And especially in the more rural parts of our state and other states, this is a huge issue in terms of respecting and preserving independence and autonomy, but also balancing risk and safety. I would encourage you to think about driving. You know, we often do it on autopilot. You know, that's one of the things you hear from people sometimes is, boy, 10 or 15 miles will go by and I have no clue what I've been doing. Somehow I got to where I was going. So it's overlearned, but if you think about the cognitive domains that are involved in driving, it's pretty much everything but expressive speech, right? I mean, there's attention, concentration, judgment, visuospatial skills, visuomotor integration, reaction time, processing speed, all these things. And for those of you who have had conversations with patients around discontinuing or retiring from driving, you also know that there are psychological aspects to this. People get depressed. We've had folks get suicidal. They get anxious when they can't get to where they think they need to go versus where they actually need to go sometimes, which is also a piece of driving and conceptualizing driving as a privilege. It's not a right. And that is a difficult conversation to have sometimes, but to put it into that framework can be useful. Having been subpoenaed by the Secretary of State in a driving-related fatality for someone that we encourage not to drive, I can tell you that there are legal and ethical dilemmas that come up with this also. So, lot to it. It's a highly complex and highly fraught with lots of emotions. The other thing that's worth noting too is that the vast majority of our folks with early stage dementia, typically Alzheimer's disease, but also vascular dementia, Lewy body, frontotemporal, will continue to drive and will continue to pass an on-the-road test. And one of the initial recommendations was, boy, you should go back to the DOL, rerun through that process. I think the record I have had has been 8 times before someone finally passed. And it's not the same as a full driving evaluation with an occupational therapist or a certified driving rehabilitation specialist, and we'll talk about the difference a little bit there. The group with the highest risk, of course, are those with mild dementia, and that makes some sense when you think about who continues to drive for our population with dementia. It tends to be the folks in the mild stages. We also know that the research that's out there would say that office-based assessment tools, something like the Mini-Mental or the Minicog or the MoCA, aren't spectacular and certainly aren't a unilateral piece that would make the decision if someone retires from driving or continues to drive, but they're maybe best conceptualized as setting up the stage for a more thorough evaluation. 2010, American Academy of Neurology put out some practice parameters around driving assessment in older adults with cognitive impairment. Level A evidence is a CDR that's equivalent to mild cognitive impairment or early stage dementia. Although you see the stat there, the vast majority are still found to be safe to drive and require some more careful assessment. The other level A evidence is don't listen to your patients because they're not accurate and they typically either lack insight or don't perceive difficulties with driving. So the next tier down is the data that you would get from their caregiver or their collateral. And there are some standardized questions to ask about that. So it's not just an open-ended, how's their driving? That usually does not get at it. Level C is a Mini-Mental 24 or below, history of actual motor vehicle citations or accidents, changes in driving habits. And having done this for the last 15 years, my driving assessment, office assessment, has gotten to be about 20 minutes typically sometimes, if someone doesn't pass the first screening questions. So there's a lot you have to ask about changes in driving habits, situational avoidance, and then certainly, and we see this with our folks with FTD and other frontal lobe changes, impulsivity, aggressiveness, anything like that is a clear trigger for further assessment. Level U evidence was neuropsychological evaluation and driving rehabilitation. So not that they don't work or have any benefit, but just haven't been studied enough, don't fully know. So when you're doing a careful history, and a lot of this will come from that, we won't go through all of these, but some of them make sense in terms of how often do people drive, how much are they relying on GPS or someone that's traveling with them to be the navigator, changes in habits. And my approach has shifted to presuming that driving habits have changed. So I don't ask people, have your driving habits changed? Like, no, so tell me in the last couple of years, how have your driving habits changed? And usually people will be a little bit more responsive to that versus say, well, they haven't. And you get the overly defensive driver, right? Who's not going to tell you anything about their driving habits. We ask a lot about difficulty with three-point turns, tight parking spaces, mystery marks, dents, wheels. How do the wheel wells look? The question of, boy, if you knew you weren't going to get caught, how fast over the speed limit would you go? Right? And what would you do when you see a yellow light? Speed up, slow down, stop. So there's lots to ask. Following distance, people's insight into the effects of their medications on their driving ability, particularly coupled with fatigue and with alcohol. And if you look through some of the more recent news articles on driving with cognitive impairment, 3 of the past 4 fatalities also involved alcohol for someone with early stage Alzheimer's disease or another dementia. So, lots to assess. And then, of course, you want to do this with the patient, and ideally, best case scenario, you get to do it with the collateral when they're not in the room with the patient, right? Which is true for many things. You're asking about cognitive functioning, you're asking about things that are threatening and difficult to talk about. And then I've also figured out over time, you have to ask them, when's the last time you rode with this person? Because frequently you'll hear, oh no, the driving's fine, but I haven't been in the car with him for a year and a half. He just drives on his own. Right? And then also in your office assessment, starting to ask some questions about, well, what have you thought in terms of when it would be time to retire from driving? And I like the phrase retirement from driving. It's a little bit less threatening, but usually the answer to that question is, when would you know it's time to hang up the keys, is when I've had an accident. And then to say, well, boy, that's a little bit far down the line. What might be some road signs before that would say it's time to consider this or start transitioning some of your driving responsibilities? You can pepper a little bit of education around liability in there too, but that typically comes when you're having a detailed conversation about retirement. A couple of articles in the last year or so that look at screening, and hopefully you're already familiar with the data around using the MoCA to assess for cognitive changes and the advantages of that over the mini-cog or the mini-mental status examination, especially in mild cognitive impairment. So there's some data that would say, there's some cutoffs that if someone's got a MoCA of over 27, they're likely going to pass the driving evaluation. If it's less than 12, they're going to fail it. So why send them on for that unless you need some external evidence to say it's not just you, they're doing the judgment. Otherwise, it's kind of 50-50, and that might be the sweet spot of who to send for further assessment. And then MoCA of less than 18, for each point decrease in the MoCA, people are about 1.36 times more likely to fail a road test. So again, MoCA is not fully predictive, but it sets the stage for this is something we do want to check out a little bit more. When you do send folks on for more detailed assessment, neuropsychological evaluation I think is useful, but has some limitations. And what I would tell you is I usually use this as kind of like the MoCA scores, where it's if it's really impaired, there are about 4 measures that are pretty predictive for crash risk in older adults. And if they're all impaired and they're all severely impaired, there's really no point in going on for driving evaluation unless that's what it takes to convince someone. For things that people pass with flying colors, if there's still a clinical history, we'd probably want to get this checked out. And then the things that are the most predictive are visuospatial skills, divided attention, and speed of information processing. All of the 4 tests that are predictive for crash risk have those as common denominators and kind of principal components. Some people opt to then go on for a driving skills evaluation. You can think of these as your kind of private driving schools that will assess vehicle operation. They do nice work around assistive devices and other technologies, but they don't do what an occupational therapist or driving rehab specialist would do, which is a medical history. They assess useful field of view, reaction time. There are a couple of parameters and well-vetted pieces that are predictive. And then the best part is they do a functional on-the-road assessment, sometime in the person's own car, sometimes in a different vehicle, and that's really what seems to have the highest predictive validity for driving ability. The other thing that's nice about an OT evaluation is it's not a binary or a dichotomous, yeah, you're good to go, or you need to hang up the keys. There's a lot of gray area in there in terms of, well, you seem safe at about 35 miles an hour or under in familiar, well-lit locations, and you're not, have the radio on, not talking. So there's a lot of detailed recommendations that can come out of an OT assessment. They're usually covered by insurance. The challenge is for some patients that they are part of your medical record. So sometimes they want to do the private thing, which they can then opt to have in their medical record. Driving, especially in the presence of cognitive impairment, needs to be assessed every 6 months, particularly with progressive neurodegenerative components. There are a few studies that would say in about a year, people, more than half, will fail if they passed 6 months before or a year before. And of course, the survival curve for that drops with cognitive function and functional independence. And as you're doing this over time, certainly continuing that conversation around in what scenarios would you be comfortable delegating some of your driving, when will you know it's fully time to stop, what's the buy-in from the family, and certainly I'm always amazed at how little information people have around liability. And if you have evidence of cognitive impairment in your medical record, get into a questionable fault accident, the other party's attorney subpoenas your medical records. We've at least had insurance companies say, we're not covering this, and other times people have been found liable. So, especially if there's been a recommendation to discontinue driving, and people continue despite that. So, in terms of talking with folks about this, certainly, you can't dwell on it, but you do have to validate how hard this is, and it's not a quick 2-minute conversation. It's not a one-time conversation. To really be clear that this isn't an all or nothing recommendation. Typically, if we can catch it early enough, sometimes it is if it's progressed. And then kind of keeping an eye on our own reactions as we talk to people, especially as we perceive them as defensive or not willing to engage around this. Your interaction will shape how much buy-in someone has, of course. Resources change all the time in terms of what's offered for classes, defensive driver courses for AAA and AARP. The amount of insurance reduction you might get if you take one of those classes changes. But there's lots out there. The Hartford group has a wonderful set of documentation around conversations around driving with older adults and those with cognitive impairment. And then certainly also staying up to date on all your community resources. And these are going to vary wildly depending on where you live. So we are lucky here in Seattle and in urban areas. Rural areas, it's much harder, but it's interesting what you might find through other organizations like the taxi cab voucher program through the APDA, the Parkinson's Disease Association, which will get people to medical visits and pay for that. They've got a